topic of presentation today is venous thromboembolism in pregnancy and prevention and treatment. This topic is very important. I think as surgeons and physicians, we do come across these kinds of patients, and it is always a nightmare for us. Regarding introduction, it is a life-threatening condition and a nightmare for all of us. It is preventable and treatable. If treatment started in time, it can save lives. Venous thromboembolism includes DVT and pulmonary embolism. It occurs in about 0.5 to 2% per 1,000 pregnancies. It increases 4 to 5 folds in pregnancy and further in first postpartum period. As pregnancy is a thrombogenic state, so its risk increases 4 to 5 folds. It's a leading cause of maternal mortality in developed countries. About 25% of the patients with untreated DVT will develop pulmonary embolism, and undiagnosed pulmonary embolism has a mortality of about 40%. Thromboprophylaxis. As a clinician, confusion arises to identify early and have departmental protocols regarding whom to give, when to give, what to give, when to stop, what alterations are needed in labor and C-section delivery and postpartum period. For every patient coming to our clinics, especially pregnant patients, should have a risk assessment. This is very important and this is the key. And when to assess, this doesn't mean that if we have assessed her in preconceptional period, we will not assess her in antenatal period. This assessment should be in this manner. Like if patient comes before pregnancy, so we should look for the factors which I will discuss later. In the preconceptional period, and if she comes in the antenatal visit, we will look for these factors which I have given you. And immediate postpartum periods, intrapartum periods, and if admitted to hospital for any reason, if developed intercurrent problems, for example, infections. For prevention risk assessment scoring of venous thromboembolism based on 3 factors. Number 1, pre-existing risk factors. Number 2, obstetric risk factors. And number 3, new onset or transient risk factors. On the basis of these 3 risk factors, we will have a scoring for the patient and we will determine her thromboprophylaxis needed or not needed and for how long it is needed. And this is the main focus of today's presentation. This slide I will show in the beginning, and after discussing the table I will show it again. If the total score is more or equal to 4 risk factors, antenatally, consider thromboprophylaxis from the first trimester and up to 6 weeks postnatally. If the total score risk score 3 factors antenatally, consider thromboprophylaxis from 28 weeks and up to 6 weeks postnatally. If the total score is equal to or more than 2 risk factors postnatally, consider thromboprophylaxis for at least 10 days postnatally. The paper you have is, unfortunately, I cannot make a colored print of that, but if you can see on the very top, in pre-existing risk factors, this gives a score. In the first column is the risk factors, in the second column we should tick these risk factors and the scoring is given later on. If patient has a previous history of venous thromboembolism, now 4 numbers is given, 4 marks are given. So we will take this. It depends on this event is not related to major surgery. Like if a patient has a major surgery, she is prone to have DVT. But if she developed DVT without any history of surgery, this is very high risk factors. And in these patients, she should have thromboprophylaxis throughout the antenatal period and postpartum period. No other risk factors needed to be considered here. And the previous VTE provoked by major surgery is given 3 marks. If a patient has a known high risk thrombophilia, which is given 3 marks, and for little bit explanation. Thrombophilia could be heritable and it could be acquired. The heritable varieties include antithrombin 3, Venous, C, and factor 5 latent mutations, and there are few others. And the acquired includes antiphospholipid syndromes with high titers of anticardiolipin antibodies and leukocytic coagulants. These patients will consider a score of 3. Medical comorbidities. If you can see, the comorbidities are very high comorbidities, like patient with cancer, heart failure, active SLE, inflammatory polyneuropathy or inflammatory bowel disease, nephrotic syndrome, type 1 diabetes with nephropathy, not only type 1 diabetes. Sickle cell disease, current intravenous drug abusers. The other risk factors, if you can see, is not given in the red format, so it is yellow and one score for each of this. Like if patient has a family history of VTE, first degree relative, no low risk thrombophilia. Low risk are those which are heterogeneous for the genes. Like if they are homozygous for the genes, this will be high risk thrombophilia. If they are heterozygous, this will be low risk. Age more than 35 years, obesity, it is 1. Not 0, 1A or B. 1A is if the BMI is 30, and if BMI is 40 or more, it should be given 2 numbers. Parity more than or equal to 3, parity 3 and more, smokers and gross varicose veins, which is extending up to the legs, thighs. The first pre-existing risk factors, I think I have made it clear. If any confusion regarding this, we can discuss later on. The other risk factors which arises in the pregnancies. This includes obstetric risk factors, preeclampsia, assisted reproductive techniques taken like IVF, multiple pregnancies, one number for these. Cesarean section and labor. This is emergency cesarean section, and as you can see, these 3 numbers are given for it. An elective cesarean section, 1 number, operative vaginal delivery, prolonged labors, PPH, more than 1 liter of blood loss, or stillbirth. These factors will take number. Transient risk factors includes any surgical procedures in pregnancy or peritoneum except immediate repair of peritoneum, like we have some patients with lacerations or vaginal repair. This will not be considered as a high risk surgical procedure, or other like appendectomy or PTM. Any other surgical procedure in pregnancy or peritoneum will be given 3 marks. Hyperemesis or dehydration. Ovarian hyperstimulation syndrome is also given 4 marks. If a patient comes with high risk, high number ovarian hyperstimulation, she should be started with the prophylaxis in the pregnancy. Current systemic infections or immobility is also given number accordingly. So is it clear? I think with using this, we do forgot this numbering scoring. That's why a handout is given, and I think if you use this handout, we will not miss the numbers to be given out. A simple case I have made for scoring. A 37-year-old private parida with history of IVF conceptions. She is having twin pregnancy. Her BMI is 35. No other risk factors. Can anyone help me? What will be her risk score?
37 is 1.
Yes.
IVF is 1.
Yes. 2.
Twin pregnancy is 1.
Yes.
BMI is 1. 35.
So the score is 4. 4 or more, high risk. So what would you say? What you will need? Prophylaxis from?
60. Throughout and post 80.
Start of the pregnancy when she will come to us till 60. So what is the anticoagulation options in pregnancy? Low molecular weight are the agent of choice for antenatal and postnatal prophylaxis. Doses are based on the weight of the patient and is usually preconceptional or post-antenatal weight we take. Unfractionated heparin is an alternative if low molecular weight is not available or contraindicated, like in case of patients having heavy bleeding or placenta previa, placenta abrupta, which we can expect heavy bleeding, so we may change this to unfractionated. Regarding the doses, it looks a little bit complicated, but it is simple. Because if you see, if a patient has a weight less than 50, which is very unusual, so it's 20 milligram. Mostly our patient falls in the category of 50 to 90 kg. The dose is 40 milligram once daily. Weight above that, 91 to 130, dose is 60 milligram. And further 20 milligrams is treated if it is 131 to 170, and more than 170, which is very obese patient, so it will be 46 milligrams per kg per day. High prophylactic doses for women weighing 50 to 90 kg will be 40 milligrams 12 hours a day, and it is will be required in thromboembolism positive and previous VTE patients. And low dose aspirin is not recommended for prophylaxis in obstetric patients. Warfarin, sometimes we come across that it is written in literature that it can be given if patient is already on warfarin, but this is based, I searched the literature and the American guidelines and RCOG guidelines and Canadian guidelines, all have a consensus that warfarin should not be given antenatally. It is a vitamin K antagonist and it crosses the placenta. It has increased risk of congenital anomalies, including warfarin neuropathies and CNS abnormalities, which includes hypoplasia of the nasal bridge, congenital heart defects, ventriculomegaly, agenesis of corpus callosum, and approximately 5% of the fetuses exposed between 6 to 12 weeks of gestation. This incidence is dose dependent and higher if the woman is taking more than 5 milligrams per day. Other complications: increased risk of spontaneous miscarriage, stillbirth, neurological problems, and in both mother and fetus. Warfarin, when it can be given? Warfarin, there is a little bit of information about that. It can be restricted in few situations, like if women have a mechanical heart valves. So she will be very high risk of thromboembolism in the pregnancy. Then mothers always come first that the baby we can give her warfarin. Women receiving long-term anticoagulation with warfarin should stop their oral anticoagulant therapy and change to low molecular weight as soon as pregnancy is confirmed, and ideally within 2 weeks of missed period and before the 6 weeks of the pregnancy, because after that the organogenesis period will be start and the baby will be affected. It can be converted from low molecular weight to warfarin postpartum. When the risk of hemorrhage is reduced, usually within 5 to 7 days after delivery. Warfarin is safe in breastfeeding. So if a patient is cannot continue with low molecular weight postnatally, we can convert her to warfarin postnatally. Clinical presentation. Now, the main topic was thromboprophylaxis, because if we identify in time and we will calculate the risk factors, the patient will not develop hopefully this phenomenon. But if she develops, the clinical presentation, what will be the clinical presentation? I think each one of us should know this and suspect this. Like it should be a diagnosis of exclusion. First we will suspect and we will not wait for the confirmation and we will start treatment. DVT mostly happens in pregnancy in 88% in left leg, 71% in iliofemoral vein, not involving calf's vein. So most of the time I also personally do palpate or press the calf muscles of the patient to assess that she is having DVT or not. We should raise her stockings or that clothing, then we should assess the thigh portion that she is having any symptoms of DVT or not. And Well's clinical criteria for VTE reduction is not validated in pregnancy. The signs and symptoms, as you can see, the picture is here. It is in the thigh mostly it happens, and it is usually proximal. And patient comes or patient will complain from unilateral leg pain or tenderness, swelling in the extremities. These are symptoms and signs. Increased calf or thigh circumference, increased temperature, prominent superficial veins or pitting edema may be present. Regarding pulmonary embolism, 2/3 occurs postpartum. The symptoms of pulmonary embolism include sudden unexplained difficulty in breathing, tightness in the chest or chest pain, hemoptysis, feeling very unwell or collapsing. Treatment will be stabilized, oxygen, and hemodynamic support and evaluate simultaneously. So I will not go in details of acute management. This is multidisciplinary team involvements, everyone should involve senior around and should consult hematologist, pulmonologist, and the staff available anesthetists so that we will not miss the case. Stabilize oxygen therapy, start treatment. Start treatment is very important. Confirm diagnosis later on. What investigations will be needed? This is another topic which makes me confused also, that what should we do if we suspect, what we should not do, should we send the patient for investigation, will it deteriorate or not? In a clinically suspected DVT or pulmonary embolism, low molecular weight heparin treatment should be commenced immediately until the diagnosis is excluded by subjective testing or unless treatment is strongly contraindicated, like if we have patient which is she is heavily bleeding, so we can consider a little bit delay, otherwise we should start immediately with the molecular weight and therapeutic dose. Therapeutic dose is usually, which is once daily, is converted to twice daily. Okay, if she is taking 40 mg once daily, so it will be 40 mg twice daily. For DVT, if you suspect DVT with symptoms and signs, duplex ultrasound scan of both legs with symptoms and signs present. If the ultrasound confirms the diagnosis, continue the treatment. If she is in postnatal period, for 6 weeks postnatal. If the ultrasound is negative, but signs and symptoms continue, so continue the treatment and repeat scan or MRI is needed after 1 week. So I also made it on this board, so a little bit I can rephrase on this. If you can see what happens to us if we have a patient with a swelling of the legs and she is post-operative, or she is have a high, we score her at that time also that she is high risk for DVT, then what we will do, ultrasound. We will start the treatment and then we will do ultrasound of both legs. If positive, no other investigation is needed, just continue the treatment. If it is negative but sign and symptoms still present, so we will continue the treatment and repeat the scan or MRI after 1 week and then reassess. It is not a matter that if we have assessed once, then we will not reassess again. Regarding pulmonary embolism, suspicions of acute pulmonary embolism, patient should have, as I mentioned, start of the treatment. Start of the treatment and should have an ECG and X-ray chest. These are easily available investigations. So if we suspect pulmonary embolism with signs and symptoms of DVT, because in the start I mentioned that in patients, 25% of the patients have both problems together. So if we suspect both together, ultrasound is the easily available method to be done. And if it confirms the DVT, then no other investigation is done, because the treatment is same for both of them. But if the symptoms are not present, like patient doesn't have leg swelling or anything else, then we should advise for a ventilation perfusion scan or a CT angiogram. Ventilation perfusion scan is preferable for the diagnosis of pulmonary embolism for patients who have a negative X-ray test. Because if she has a finding in X-ray test, then ventilation perfusion scan will not help. At that abnormal X-ray, we will do CT. So for abnormal X-ray test, we will do CT. For normal X-ray test, we will do ventilation perfusion scan. This is also I little bit made it. Like patient with signs and symptoms of DVT and pulmonary embolism together, ECG, X-ray test and scan of the legs. If scan of the legs present, positive, no other investigation, continue treatment. But if no symptoms of DVT, then we will do X-ray test. If it is abnormal, then ventilation perfusion scan for confirmation and abnormal X-ray test with CT angiogram. Regarding the initial treatment for DVT and pulmonary embolism, again low molecular weight 1 mg per kg subcutaneously every 12 hours, or unfractionated heparins can be given 110,000 units to 20,000 units, usually 150 to 200 units per kg subcutaneously every 12 hours. Lower doses is less than 50 kg. Just dose to achieve activated partial thromboplastin times of 1.5 to 2.5% at 12 hours. So 6 hours. So there are some precautions, like if patient is, we We have started her anticoagulations, thromboembolism therapy in the pregnancy antenatal period. What will we do in the labor at the time of labor and delivery? I will not go in much detail because it is quite detailed topic, but I will summarize few points which are important. Like patients with proximal delivery or pulmonary embolism within 2 weeks of delivery can be switched to intravenous fractionated unprotected heparin, which is discontinued 4 to 6 hours prior to expected delivery or epidural anesthesia administration. Because the reversal is easy for unfractionated heparin with protamine sulfate, and we can always control the dose, so that is why we will switch to this. And for scheduled induction or cesarean section with blood pressure using therapeutic low molecular weight, discontinue 24 hours before the delivery induction. With prophylactic dose, the 50% of the dose should be given a morning prior to the expectant. So what we can say in a simplified way, for therapeutic 24 hours and for prophylactic reduce it to 50%, or we can reduce at 12 hours. For spinal and epidural anesthesia, therapeutic avoid for 24 hours as I mentioned before, and prophylactic avoid for 12 hours. Unfractionated anesthesia can be administered after 4 to 6 hours in women receiving 10,000 to 20,000 per day. Women with proximal DVT or pulmonary embolism, I mentioned this point before. So what is the summary? VTE is common in pregnancy and a leading cause of morbidity and mortality even in developed countries. Several professional societies have published recommendations regarding thromboprophylaxis to improve the outcomes. Low molecular weights are the agents of choice for antenatal thromboprophylaxis as well as the treatment when VTE is diagnosed. Heparin and warfarin are safe with breastfeeding. Every department should have a safety bundle. These guidelines I have chosen from the material I have chosen from the Advanced Life Support Guidelines of the American Obstetric Associations and RCOG guidelines. So they mention us that each unit should have a preparation for anything emergency happens. So we should recommend 4 hours. We should remember 4 hours. First is readiness. Every unit we should describe, or we should be aware that our team is ready for an emergency. Recognition. Every patient, how does our team recognize patients are experiencing deterioration? Response. Every unit, what is your response to the emergency? Reporting. Every unit, how does your team improve the learning? Because by reporting or auditing, so we can improve our adverse outcomes. So these 4 hours are very important, and we should always consider these hours in emergency situations. Thank you. Question?